Yeah, we are live. Good. It's
Okay.
working.
Okay, good.
Yeah. George, can you hear me? Yeah.
Yes, I can hear you.
Good. Now let me check for my mobile. The YouTube is working well.
Okay.
Sir, it's working well, sir.
Oh,
the
YouTube is working. YouTube is working
Yes.
well.
Yes, YouTube is working.
Okay. Good. So, George, Dr. Yamuna, you may know her, I'm sure.
Hello, sir.
Hi, Yamuna. Are you in Apollo or?
Yeah, sir, I'm in Apollo and I'm taking care of infection control, sir.
Okay. Right.
She's also one of our trustees.
Sure. And are you mainly in cancer hospital or?
I'm in main Apollo, taking care of also children and women's hospital, sir.
Sure.
Vasant will be 10 minutes late, but we will exactly 7 o'clock. So 2 more minutes, George, then we'll go live.
Sure.
And we will be, of course, it will be available on the YouTube, and our main dissemination will happen after that. We'll send the link to everybody,
Sure.
It's 7 o'clock. Good evening, Dr. George.
Good evening, Gafur.
Welcome to the webinar by AMR Declaration Trust. And today we have got a special guest, Professor George M Varghese. He's a professor of infectious diseases at CMC, Christian Medical College, Vellore in India. Dr. George is the lead author of a landmark paper in tropical medicine, a landmark paper on Scrub Typhus. It's an amazing teamwork and published in New England Journal of Medicine. You all know that New England Journal of Medicine is one of the most reputed journals in the field of medicine. And this is an achievement by Indian doctors for solving the global crisis of, it's a crisis. The Scrub Typhus kills 150,000 patients every year. And Dr. George will explain to us the details of the study and what contribution this wonderful study is going to make to the field of infectious diseases. Dr. George, welcome to the webinar by AMR Declaration Trust.
Thank you, Gafur, for your kind words of introduction. And it's my honor to take part in this informal discussion. And thank you for inviting me to this discussion. And I hope that this discussion will make the increase the awareness about the disease, as well as the management of this particular problem, which is a major public health threat, which is kind of neglected in the endemic region. And therefore, it is something which is really relevant and remarkable. And I appreciate you taking your time and giving this priority and inviting me for this discussion. Thank you very much, Gafur.
Dr. George, for the sake of the general audience and the public, would you please explain what exactly Scrub Typhus is and what impact this disease has got to the disease burden at the global level?
Sure. So Scrub Typhus, as you have mentioned, is a life-threatening bacterial disease caused by the bacteria called Orientia sutsugamushi. It belongs to the group of rickettsial organisms, which is an intracellular bacteria, which causes this infection. This infection is actually transmitted by the larval stage of the mite, an insect. Now, this larval stage of the mite is not even visible to the naked eye. So therefore, people usually don't recognize that they've been bitten by an insect and they have developed a disease. This commonly manifests with fever. Along with that, people may have headache, cough, breathlessness, altered sensorium, etc. Now, the recognition, a lot depends on the awareness. Now, the awareness is better, but it has been quite abysmal in the past several years. Over time, it has been increasing. Now, in terms of the burden of disease, it's something which is grossly under-recognized. So we don't really know the exact burden of disease. The endemic area is called Sutsugamushi Triangle, basically the geographic region in South and Southeast Asia, with India being one of the countries where there's huge burden of disease. Now, in this endemic region, roughly about 1 billion people are at risk of disease, and about 1 million cases, estimated number of cases occur annually, and about 150,000 deaths. Now, this is, a lot of it is based on estimates. If you look at our own data, we tried to look at the burden of the disease in India. So a few years ago, we compiled all the reported cases over a decade. Roughly about 20,000 cases were reported in the literature. And we found that if you look at the reported cases, it's roughly about 10% of the actual number of cases. So it's just the tip of the iceberg. And we had also done community seroprevalence. And we were surprised to see that this is particularly in Vellore districts and different locations sampled systematically. And we found that the seroprevalence is about 31%. There is another seroprevalence study, again published from India, almost the same figure, about 34% or so. So roughly about 1/3 of people are exposed to this organism, and they have got the antibodies, and they've been exposed to the organism sometime in the past, and they have immunity, either with an overt clinical disease or subclinical infection. So this is one of the grossly under-recognized problem. This doesn't even figure in the WHO neglected tropical disease. So all of us say that it's so neglected that it doesn't even appear on that list. But over the past decade or so, the awareness has been better. Now it's been recognized much more widely, and people are aware of the disease and the problems.
Oh, Dr. Joe, thank you very much for, explaining to the audience how common scrub typhus is. Because even in our infectious disease practice in Chennai, we don't see scrub typhus every day. Once in a while, we see a patient with Eshka. But the data you provide, the seroprevalence data you now explained, just inform us that it's a common disease we are not looking for. And if you don't look for, we don't find. So we look like it's a missing elephant in the room.
Yeah, absolutely. So there are two things. One is the gross under recognition, and secondly, in the major cities, it is not something which will be that common. As you know, people who are exposed to the vegetations, particularly the agricultural workers and people like that. So it is much more common in the rural and suburban areas. That does not mean that it does not happen in the cities. A park is enough. In fact, we have had patients from Guindy, well-to-do family. They have a garden, who's living in Guindy. They have a garden, comes with fever. They've been given co-amoxiclav. Fever was persisting. Found an Eshka, and of course, the diagnosis was confirmed and treated, completely recovered without any complications. So it does occur in cities, in people who are exposed to the vegetation. But like you said, it is the elephant in the room, because the awareness is quite poor. It's not recognized. For the burden of the disease is less well known, and it's not recognized well.
As an infectious disease physician myself, before reading your paper, we all thought we know how to manage scrub typhus. We give doxycycline or azithromycin. Why do we need a new trial? What really prompted you to conduct this trial, even though we all knew how to manage scrub typhus?
That's a good question, Gafur. It actually was an evolution of events. So basically, in somewhere around 2000, 2001, we started recognizing these patients who come with acute febrile illness. And at that time, initially, we didn't know what we were dealing with, acute febrile illness and multiple organ involvement. We look for most of the common causes such as leptospirosis, falciparum malaria, dengue, typhoid. All those were negative. Then we did a systematic study, and at that time, we didn't have any confirmatory diagnostic test in India, and we collected about 45 patient samples after IRB approval, systematically done, and we send the samples to a WHO reference laboratory in Marseille, Dr. Didier Raoul's lab, which confirmed Orantia tsutsugamushi and ruled out all the other etiological causes in these patients. And this was published in the Annals of New York Academy of Sciences in 2003. Now, after that, our work has been on, a lot of it was on the epidemiological aspects. Who is developing the disease? What are the risk factors? What are the predictors of mortality? How can we recognize faster? Try to improve the awareness, so on and so forth. And then eventually we worked on looking at the organism. With an ICMR grant, we looked at 3 regions of the country, Shimla and districts around in the north, Shillong and districts around in northeast, and Vellore and districts around in the south. We genotype the organism which is circulating in different parts of the country, laying the foundation for the newer diagnostics and vaccines and all that. Then we eventually moved on to the diagnostics. What we really found after about 10 years of work, we asked ourselves, we have been working on this disease for about 10 years. What difference did we really make? And that question was very gratifying. I mean, the answer to the question was very gratifying to us. We found that in the initial years, the mortality of patients or case fatality of patients who come with Scrub Typhus to CMC was about 15%. About 10 years later, the case fatality was about 6%. And we could actually make a significant impact in reducing the mortality just by two things: by early recognition, awareness and early recognition, you could actually reduce the mortality. And when we re-examined at that time, severe disease again was the major problem. The 24% was the mortality at that time in patients with severe disease. So we decided we will address that. And this was the time, like you said, you and me, we used to believe that doxycycline is the drug of choice. And that's what majority of the physicians across the world believe. Later, evidence of azithromycin in milder cases started coming in. Patients with less than 100, less than 100 patients in small randomized controlled trials showed that in mild disease, maybe azithromycin is equally effective. We have no idea whether it will work in severe disease. People had their own doubts. So at that time, I'm talking about 7 years ago, at least, what people used to give was, physicians used to give, some used to give doxycycline. If you remember, at that time, we never had IV doxycycline. So people used to give doxycycline through NG tube. In somebody who's got severe disease on ventilator, gut mucosal edema, oral bioavailability is a question. People started questioning, is part of the mortality because of that. Some people used to give azithromycin, although very many really didn't believe that would be the answer. And some used to give IV azithromycin and oral doxycycline as a combination. So that actually formed the rationale in deciding. So addressing the severe disease with the mortality of about 24%, what is the best treatment option was the question. Is it doxy, or is it azithro, or is it a combination of the two, all given IV? So the IV at that time, with a lot of advocacy and things like that, generic manufacturers started manufacturing again. MSF helped a lot in the advocacy, and now we have IV doxycycline available. So when we started the trial, we could actually pick that up and do the trial.
See, the conclusion of your study is really, path-breaking. It can reduce the mortality of the global Scrub Typhus burden patients, significantly. What exactly is the conclusion or finding of your landmark study?
So the conclusion of the study is that we looked at the primary outcome as a composite outcome. We thought that, with a lot of these, the mortality, although we find that about 20-25% mortality in severe disease. You may have a spectrum varying between 15% to 30% or so. So we thought mortality alone, if you have to concentrate on that, you need much larger numbers. So we decided to do a composite endpoint, composite of mortality at day 28, persisting complications at day 7, which means that anybody who requires respiratory support, ventilation, oxygen requirement, all that is defined as persistent complication on day 7. So like that, each organ involvement we define, inotropic support for cardiac involvement and all that. So we defined what is persistent complication. So in the composite, mortality at day 28, persistent complications at day 7, and persistent fever beyond day 5. These were the composites. And the composite outcome we found that is much lower, significantly lower in the combination therapy arm, 33% versus 47 and 48% in doxy and azithro arms. In the monotherapy arms, it was 47 and 48%, while in combination therapy, it was 33%. When we examined this carefully, the mortality alone, it did not find any difference between the arms. Persisting fever, it did not find any difference in the between the arms. What really made the difference is the persistent complications. Now, if you extrapolate that, and I looked at our overall mortality was about 12% in the trial. I mean, we had actually, we could see that even as you go about, the standards were improved, the mortality itself was getting better. And overall mortality of 12%, if you calculate the numbers which are needed to show a difference to say reducing it to 8%, you will need something like 1,800 patients. So if you have much larger number, you would be able to show that mortality difference. But our study did not show that. We looked at the composite outcome where the complications were much different. So you and I know that these complications essentially will prevent ICU admissions or longer stay in the ICU and things like that, which eventually, the reduced nosocomial infections and the outcome and the mortality could be potentially reduced if you reduce those complications. So essentially, the study found that faster resolution of complications with combination therapy.
So in simple terms, for the sake of the general audience, earlier we used to give doxycycline or azithromycin, and you combine doxycycline and azithromycin, and you found that if you do give a combination of these two drugs, we can create a significant reduction in the complications. And we know that as doctors, we know that if there's a significant reduction in the complication, that will lead to significant reduction in the mortality. Even though study doesn't show a statistical reduction in the mortality, that's because we need a much larger sample size to find that, but to show the statistically significant reduction in the mortality. But we do know that if you reduce the complication, naturally the mortality rate will be lower.
Absolutely right.
So you, even though you very simply put the conclusion of the study, conducting such a large randomized control trial is a mammoth task. We all know that. How could you do such a large trial in our country? Because if you look at the tropical medicine, before your trial, what I can remember, Dr. Shyam Sundar from Varanasi has done some excellent work in the Kala Azar. Apart from that, I don't remember any path-breaking papers in tropical medicine from our country. So how could you do such an important, difficult to do trial in our country?
Gafur, it is, for me, it was a huge learning, first of all. But a lot of things came together. First of all, the funding. It is not easy to conduct a clinical trial, and it requires a lot of resources. If you, I mean, most of the clinical trials, it runs in billions. And this is an investigator-initiated study, and I was lucky to get funded by Wellcome Trust DBT Alliance. This was a 5 crore grant, 5 crore rupees, which is not an easy task to get. So I must say that, I mean, I did put in a lot of hard work, but I must say that there is an element of luck as well. I was lucky to get that. And I'm sure I was passionate about addressing this problem, and I had systematically, shown that there are multiple problems which we had solved earlier. And we also had supporters helping us in the conduct of the clinical trial. As you know, conducting a clinical trial, it's a huge process, right from developing a protocol, setting up a DSMB, creating a DSMB charter, getting your team, the IP management, data management system. It's a humongous task. So I kind of, if you look at that kind of capabilities, most of the institutions in India, we are still not at that level. This does happen on a day-to-day process in several developed countries. So I had to, even in an institution like CMC, we did not have a good clinical trial unit which could take care of all these aspects. So I had to actually, pick and choose different things. For example, database management. You know that all these data and the database management, if you go to a private company, somebody like Oracle, it will cost, several lakhs of rupees for the database management. So your cost will be beyond what the resources you have. Just to give you an idea, the insurance for the trial, what I conducted alone, the premium for the insurance alone was 10 lakhs. Just the insurance. So the database is going to be much, much more costlier. I was lucky to get some of those with our collaborators in Thailand, in Moro. They had the Oxford license. So they gave us the database where we could actually, we didn't have to pay anything. So a lot of these things and the investigational product management, it's a huge process. You have to have everything documented clearly, every single drug accounted for, and temperature control, even while you are shipping. It's a whole lot of process. So I had to get a CRO to help me with that. So to me, it was a huge learning. Every step of it, I learned as I went along, but I made sure that I will do the according to the international standards. I not only registered the trial in the CTRI, which is a requirement. An academic trial, you need not get DCGI approval. It took longer, but I decided I will get the DCGI approval. I did get DCGI approval. I had to go there for a couple of meetings, present the study, finally get the approval. Took a little longer, but I made sure that I did it according to the international standards. Although it was little more difficult, I think it was worth it. The learning which I've had is immeasurable, and I'm sure if somebody who's venturing into this, I'm sure I will be able to help them in a much better way. So this, like you said, it has been a humongous task, but it was a journey well worth it, and I really enjoyed the journey throughout.
Yes, thank you, George. We all understand that, how difficult it is to do a study on a tropical medicine disease where, drugs, azithromycin and doxycycline are generic medicines. There's no support from pharmaceutical industry. We all know about big multinational, big international studies where Indian centers are part of, but they're all new drugs by big pharmaceutical giants with millions of funding, and they can do the trials well because there's a lot of money involved and support involved. But doing such a trial using 2 old generic medicine in a neglected tropical disease with 5 crore funding, we all know that 5 crores is actually such a small amount for such a big trial with international standards. It's an amazing work you did through all these difficulties and hurdles you overcame. Vasant?
Yeah, hi. Good evening. Hi, George. Good evening. How are you?
Hi, Vasant. Nice to see you.
And at the outset, congratulations on this landmark paper. Heartiest congratulations for this paper. Great.
Thank you. Thank you.
Yeah. I had a couple of questions. One is, did the age or comorbidities influence the clinical outcome in your study? And the second is, any experience of using high-dose doxycycline, that is 200 milligram twice a day, than the standard of 100 milligram twice a day?
Okay, so the first question, the age or comorbidity didn't really matter, Vasant. It was a slightly younger population in their 40s. These are people who are working. Most of them are working in the fields and things like that. So very active people. So it's not like, COVID where the elderly is affected and things like that. And the comorbid people are disproportionately affected with severe disease. No, it was not like that. So the age and comorbidity didn't really matter. It was just representation of what was the comorbidities in the population. So that didn't really matter, and it was well balanced in all across the 3 groups. The second question, the doxycycline dosing, Vasant. What we gave was 200 BD on day 1. That is like a loading dose, followed by the rest of the 6 days, 100 BD. So that's the usual dose. And if you load it, 200 BD on day 1, followed by 100 BD. Now we have done the drug level measurements. Doxycycline in the plasma, very good levels. So we had actually monitored the drug levels as well. So they achieved very good levels.
Thanks, George. Thanks for that, your answer. Thanks.
No problem.
George, before this trial, if you would have seen doctors combining azithromycin and doxycycline, we would have thought maybe that's antibiotic misuse. For one disease, two drugs. But combination helps. Not in all the diseases, but with evidence-based data like this, with evidence, we can use combination, and that's a contribution to the world of antibiotic stewardship. Because general doctors and the public believe with these antibiotic stewardship doctors, infectious disease doctors, they only want to stop antibiotics. They only want to use one narrow spectrum antibiotic. They're all difficult trying to control the antibiotic usage. But you have produced evidence that combination works in selected diseases. And what is the scientific basis behind this combination? Rather than giving doxycycline or azithromycin alone, if you combine these two, why should there be less complications and indirectly less mortality?
You raised a very relevant question, Gafur. Like you, my bias was also against dual therapy. I was also not for combination therapy. But we decided to have an arm where there is a combination therapy because many physicians were using it. That was primarily the reason was there was no IV doxycycline available. So because many physicians felt that that was the standard of care, we decided to include that. Now, the scientific reason, I don't know the answer completely, but I'll tell you the insights, what we have developed. So we are also trying to find a scientific explanation for that. We looked at the concentration of these drugs, both in the plasma of both these drugs, azithromycin and doxycycline, both in plasma as well as intracellular. So we took out the buffy coat and the peripheral mononuclear cells, and we standardized the number of cells and looked at the drug levels in that. Now, what we found was doxycycline achieves very good concentration in plasma, but hardly any inside the cell. While azithromycin, the levels in plasma are not great, but concentration in the inside the cell is significantly higher, significant concentration intracellular. So that is something which is known, that azithromycin concentrates intracellular. So what we believe is, I mean, for an intracellular organism, an antibiotic which achieves better concentration inside the cell may have a better killing. So what we believe is that the combination have a synergistic effect. We are trying to address that scientifically, looking at how does it really cause that. We know that the concentration difference, there is a difference, and although both these drugs inhibit the protein synthesis of the bacteria, it acts at different sites, and therefore it's a complementary mechanism as well.
So yeah, so the two antibiotics are helping each other. I'm just repeating what you told because this is a bit complicated mechanism. So for the sake of the general audience, we're watching now, and those will be watching later through our recorded videos. Doxycycline and azithromycin, both of them act on the protein synthesis. And I read in your paper that azithromycin acts on the 50 years and doxycycline acts on the 30 years. Am I right?
Yeah.
And so even though both inhibit the protein synthesis, they help each other. And that's from the protein synthesis inhibition point of view. And as you mentioned, the doxycycline doesn't have great concentration in the cell, intracellular, where azithromycin has got excellent concentration inside the cell. Until, I read your paper, I was not aware of this difference in concentration. We all believe that doxycycline is the drug of choice, very good activity, very good intracellular concentration. But after reading your paper, we changed our understanding of action of these antibiotics.
Yeah, one more clue we had, Gafur, one more clue, in the sense that when we looked at we did serial PCR. Patients who have been on therapy, day 1, day 3, day 5, day 7, like that, we did the PCR. So the bacterial killing was found to be much better with combination therapy, meaning PCR becomes negative sooner.
Yeah, so you have a PCR evidence as well for the
Yes.
conclusion you reached.
Yes.
Great.
Yes.
And the idea of doing that PCR was excellent.
Yeah.
Sir,
So
I have a question.
Yeah, Yamuna has got a question. After that, Ashwini.
Sir, how many cases have you found who presented clinically to the ICU, severe cases with eschar? Were there a multiple eschar, or was it only a single eschar? How was it correlated with these scrub typhus infections?
Okay, so the eschar, Yamuna, if you carefully look for it, when we say carefully look for, usually it's in the hidden areas, like in the axilla, groin, under the scrotum, etc. So unless the doctor carefully search for an eschar, invariably you will miss it. If you carefully search for it, you might find it in about 60% of the people. The remaining, it may have been very small or fallen off, or it's not noticeable. I'm talking about even patients who have got a PCR confirmation of the disease. So, and when you look at single versus multiple eschars, in scrub typhus, usually it is single eschar. Multiple eschars are rare, but we do see occasionally multiple eschars. On the other hand, Rickettsia africae, which again is another rickettsial organism which has an eschar, that produces actually multiple eschars. And that's a painful bite, and you can see multiple eschars and all that. So scrub typhus, it is a single eschar, which is the usual manifestation. The how many of them develop multiple organ involvement and ICU requirement? So about at least 1/3 of them will go on to develop multiple organ involvement and requiring ICU. 20-25% of them will end up on ventilator. So the trial chose patients with severe disease. We define each organ involvement severity. We actually chose the severity criteria for each organ. Like, for example, saturation of less than 92, with chest X-ray infiltrates, cardiovascular involvement with a systolic BP of less than 90, so on and so forth. Each organ we define what is severe disease, and they have to fulfill at least one organ, significant involvement of at least one organ, and many may have a combination of organ involvement.
Thank you, Dr.
Thank you,
George.
sir.
Ashwini, you got a doubt?
Yes, sir.
Clarification.
So, yeah, it's regarding the duration of therapy, sir. So when we use doxycycline for severe scrub, normally we think of 10 to 14 days of therapy. So how did we nail it down to 7 days of therapy? Was there any significant thought process behind it?
Yeah, Ashwini, generally 7 days therapy is conventionally considered that is enough. Now, the indirect evidence from the trial is that the bacterial clearance occurs within the first few days itself. Usually in 3 days, it's all gone. 3 days, 4 days, the bacteria is all gone. Very few percentage will go beyond 3 days or so. So the vast majority will clear the bacteria in about 3 or 4 days. Therefore, you don't need to continue beyond 7 days. I mean, the antibiotic primarily is for killing the bacteria.
Yeah, let's see. The finding of the study of the 7 days is also a very good, very helpful point for the clinician. Now we know what's the correct duration of therapy.
Yes.
Dr. Sandhya?
Good evening, sir. Good evening, Varghese sir. Actually, my question is, if we are telling that antibiotic, we have to use it judiciously now, combination therapy and longer duration, actually, many courses, they are telling shorter course. Like with this combination, is it like, I know patients are getting saved, but most of our ICUs are colonized by Acinetobacter or something else. Like person gets cured of maybe gas gangrene also, or even severe scrub typhus also. But because of our ICU practices also, I feel have to be very optimal in this regard when we use such broad spectrum antibiotics. Just a thought, because we had a case wherein like we had gas gangrene, one case, like we didn't know how long to continue. They did some 7 days, they brought it down, but later patient developed meningitis. I know it is not related to this case, but usually such severe cases, what I have seen is multiple antibiotics are given, and at the end of 10 days, patient gets better, but ends up having something else in his system. So, like, how do we go about such cases? And IED consultations, actually, I asked our management also, I keep asking, have a IED consultant in the college, but many of the IED consultants don't come to medical colleges, and it is a gap, I feel. And how do we actually help? Is there an online consultation for IED consultant on a case-to-case basis, so that such MDR cases can be and such severe cases, any IED rounds only for IED consults to make their time also more useful and optimally used?
Sandhya, thanks for your question. You've actually brought up huge challenges which we may not be able to solve in this webinar, but I'll try and tell you what some of my thoughts are. Number one, the first point which you brought out is about antimicrobial stewardship. The duration. So the longer versus shorter, like Ashwini was asking, conventionally, a lot of people use 14 days of therapy. We know that 14 days is not needed. So the trial actually gives you an idea that, you know, all you need is about 7 days at the most. So that way it adds to antimicrobial stewardship practices. The dual therapy is, there are very few situations in infectious disease where dual therapies are, or combination therapies are used. Number one is where there is a synergy. The typical example is enterococcal infections, where you combine ampicillin with an aminoglycoside, you get a synergy. 2 plus 2 is not 4, it is 5. So where you have a synergy. So possibly something similar to that is what is happening in Scrub Typhus as well. There is a possible synergy. So there is an advantage, and there are situations where you use combination therapy. TB is another typical example where you use combination therapy to reduce the development of resistance. Even if more than one drug is susceptible, if you use a single drug, quickly patient will develop resistance, and that will become a challenge. So you use a combination therapy. So there are only few situations where you use a combination therapy. And if it's an evidence-based practice, I think there is nothing wrong with it, and it's not against the antimicrobial stewardship practices. And I think what we know from the clinical trial and the evidence so far is that there is evidence to show that some form of synergy is there. Now, in terms of people developing multi-drug resistant infections and all that, yes, it does occur. So the trial again gives you a guidance that if you can reduce the complications, if you can make them better quicker, they don't have to be in the ICU for a longer period. You can take them out sooner. They will develop less of ventilator-associated pneumonias, etc. Where you were talking about multi-drug resistant Acinetobacter, which is a major challenge in our country, and several countries. It's becoming an issue. Whether we can get online ID consultations, I wish we had lots of Gafoors and Ashwinis. They could provide online support, but eventually we hope all those problems will become less and less. Now we have several ID training programs, several champions of ID who are actually trying to help out. So the problems will slowly get solved.
Thank you.
George, I got a very interesting question from Dr. Ravi. It's actually our ID fellow. You're watching in the YouTube. I saw a mite with a scar on underside of the scrotum. Never expected that. A mite with a scar. Is it possible to see the mite with a scar?
Unlikely. I mean, there might be, I don't know, it is actually not the mite which transmit the disease. It's actually the larval stage of the mite, which is not visible. So I don't know, it may have been a mite or something else. It may not have been a Scrub Typhus eschar. Unless you test that eschar for PCR, you will never know. But unlikely that the same mite which caused the eschar is sitting there.
Yeah. Maybe it's a small baby cockroach near the under the scrotum.
Yes.
No, you are the expert. The how the eschar develops. The story is so interesting. I'm sure the general audience will be very interested to know the migration and the bite of the larva.
Yeah.
Because it bites only specific places.
Yes. So basically, one thing which is not very widely known is that the mite usually doesn't bite mammals. It's only the larvae. Mite actually feeds on the vegetation. The larval stage of the mite is the only time when it takes a meal from a mammal, usually rodents. humans are accidental hosts. So when we walk through the grass or the vegetation, this actually jumps onto you and really crawls to the area which is moist and where the skin fold is likely to be thinner. It sits there, takes a meal. That again, it forms a kind of vasculitis there, and that's what forms the eschar there at the site of the bite.
You mean the parent mite is vegetarian and the baby larvae are non-vegetarian?
Absolutely.
Sir, I have a question. What is your message on community-acquired sepsis? Like for the endemic zone with scrub typhus and a non-endemic zone, will it change the treatment, empiric choice of treatment in community-acquired sepsis?
So when we say community-acquired sepsis, Yamuna, we must look at, as ID physicians, the first question which we ask ourselves is, where is the source of infection? Or what is the syndrome with which they are coming? Is it a pneumonia and bacteremia? Or is it a pyelonephritis and bacteremia? So you find a focal source of the infection. And so although all these ends up in the syndrome called sepsis, unless we do that, we will be just giving just shotgun therapies, and which is usually broad antibiotic therapy. I don't think it is an appropriate practice. It is not in terms of appropriate use of antibiotics and scientific practice of medicine. It is not something which we should do. So we should always look at, even if somebody comes with features of sepsis syndrome, you must try and see where is the source of infection. And so in these patients with scrub typhus, although they may have manifestations of systemic manifestations, you will find that it is not like pneumonia or pyelonephritis or necrotizing fasciitis and bacteremia. Some of these are common sources of infection, where there is multiple organ involvement, commonly liver, renal involvement. There could be cardiac involvement. And in that situation, you carefully look for an eschar. And if you find an eschar, you're fairly specific. And you can actually narrow down. You can target your therapy for those. So I would still, if it's a community-acquired infection with, let's say, pyelonephritis and bacteremia, I probably would choose, if the patient is in septic shock, I would choose a carbapenem. While if it is likely to be scrub typhus, I would probably choose doxycycline and azithromycin.
George,
Thank you, sir.
is there any evidence of such combination in typhoid?
You asked again a very good question. There is a surrogate evidence. This actually, there was a trial in Nepal a couple of years ago on typhoid, and I had written an editorial. When I was looking through the literature is when it occurred to me that even in typhoid, there is a little bit of an evidence. In severely bacteremic patients, if you combine it with, if you combine azithromycin with the beta-lactam, there is a slight benefit. it is not very well evidenced, but there is an indication. As all of us know, beta-lactams are not very good agents for intracellular pathogens, but it probably will work on bacteria which is outside. Typhoid again is a lot of it is intracellular. So will there be a benefit if you add azithromycin? Maybe, but I would be hesitant in making that statement without clear evidence.
Probably you should make that your next Himalayan project of randomized control trial. And also, I just think you have unleashed a genie of combinations. Now we don't know what else people are going to do trials on combination therapy, because you found it useful, and we never thought, until I read your paper, I never thought it's going to be a combination is going to be useful. Anyway, you proven us wrong. No, you did excellent work in conducting this randomized control trial. What is your advice to young infectious disease doctors and trainees in conducting such trials? We've got so much of, the wealth of tropical diseases, but we don't do trials. We still look forward to the Western countries or Thailand or Nepal for most of the tropical randomized control trials.
Well, first thing is, asking questions about the problems which you see. If you actually train your mind to do that, you can actually solve multiple problems. It could be something which is very simple, and if you start asking questions about the problems which you face, and then try to address this. When I started with Scrub Typhus, it was, I was just finishing my MD medicine training. And when we found that this group of patients who come with acute febrile illness and multiple organ involvement, the question which we had was, all the etiologies are negative, and what is causing? Unless you ask those questions and try to answer those questions, it might be solving smaller problems initially, but there is a huge benefit or impact which you can make by addressing those. All of us are clinicians, so we derive satisfaction by helping the patients who come to us. This research actually gives you an opportunity to make an impact on a much larger scale, more wider impact. So my suggestion is, ask questions, be passionate about not only being a clinician, you should take pride in it, but also addressing some of these issues, and you will keep growing. You will, research is something which will make you grow. You will solve problems after problems, and you will continue to grow. And that's when you find much more satisfaction, and you realize that you can create a bigger impact as well.
Thank you, George. You have been an inspiration to the youngsters for doing such trials. What will be your message to the policymakers? What support we need for our young infectious disease doctors and other doctors to conduct such trials?
Yes, for policymakers, number one, when we find these these results or the evidence, we should actually try and make some kind of an advocacy. Now, Ghafoor, you have actually been very successful in the advocacy area, and I have not been so. I mean, I have not really gone into that area, but that is equally important. The advocacy, usually when you find an evidence and to become practice, it takes several years. While with advocacy, you can achieve that much faster. And you can make that that impact, on the ground much faster. So to the policy makers, for making it conducive for all these scientific advances to be taken, to be translated into policies. So, for example, here, I think we should try and address or make management guidelines as soon as possible, be it how to diagnose, how to manage, and what are the policies. So advocacy, guidelines, and also encouraging our younger researchers and clinicians to do more research, providing additional funding, support, and scientific environment where these evidences are appreciated and translated into policies.
We had 1 hour of very interesting discussion on Scrub Typhus and the new paper. On behalf of the AMR Declaration Trust, on behalf of infectious disease community and the medical community, we congratulate you on your excellent paper and the data you gave us. We are grateful to you for that data. Dr. George, thanks a lot for attending this fireside chat. Thanks a lot.
Thank you very much, Ghafoor. Thank you for this opportunity, and thank you for inviting me to this discussion.